All right. Well, we're going to go ahead and get started. I want to thank you guys for joining us. We know your time is precious, and there's a lot of webinars out there floating around right now, and there's a lot of COVID material, and so much to read is hard to keep up with. So we do appreciate you taking the time to join us today and hear what we have to say on the topic of pooled testing and how that can help with throughput and help your lab process more COVID-19 samples, as well as reduce the cost for testing those samples. A little bit of housekeeping as we get started. On the right side, you'll see a chat, QA, polls, and handout features. The chat can be used if you need to ask any questions. You can drop those in there. If you have any questions, you can also put them in the Q&A, and we'll try to thread those and keep the answers underneath those questions. There is a poll that looks like at least 15 of you have found, and we'll have some of those polls going throughout the session today. So I encourage you to keep an eye on that. And then we do have a few handouts for you to download if you're interested. One is on sample pooling, and one is on our WorkSafe offering, which is more of an employer or university solution for testing asymptomatic population. So, all right. Well, thank you guys. We're going to go ahead and get started, and I'm going to tell you a little bit about Lighthouse and who we are. So Lighthouse Lab Services, we've been in business over 16 years. We're now the combination of two companies, Lighthouse and Elite Diagnostics, merged about 6-7 months ago now. And together we've built over 100 labs, turnkey lab builds. We have 1,028 lab directors that we've placed in assignments at high complexity labs, some moderate, mostly high complexity labs around the country. And we currently have 150 labs under management. Many of you are members of our social media groups, but we do run some of the largest groups in the world of medical lab scientists on LinkedIn and on Facebook. And many of you get our newsletters as well. So we appreciate you continuing to follow us there. We try to provide good content that's always relevant for you guys. We do these webinars for free. We know some of the other options out there do charge for this content. It does cost us to put these on, so we do ask that you consider using us for our services. We'll do a light sales pitch here. If you ever need staffing, need to validate a new line of testing, you're looking to add COVID to your lab, you want to validate sample pooling, you need a lab director changed out, we would love to help with that. And that's how we're able to keep these webinars free for everybody. And so I'm going to go ahead and I'm going to introduce sort of our team. So we have Dr. Sarah Harris with us. She's our Chief Technical Officer, and she's going to be talking about a case study that we've done with sample pooling, just going over what sample pooling is in general and how that applies to the medical laboratory space that we're in right now. I'm John Harrell. I'm the president of Lighthouse Lab Services. Been doing this, like I said, for about 16 years, and I'm happy to be spending my lunch hour with you here today. We also have two experts joining us. We have Dr. Joshua Tebbs and Dr. Chris McMahon. And this is a feat in and of itself because we've got somebody from University of South Carolina as well as Clemson collaborating, working together, which you don't see those groups get together that often. And so they all do agree on this topic in particular on how sample pooling can help. And both of them come from a statistics background. So they're both PhDs in statistics, and you can see their list of accolades listed under their pictures there. And so real honor to have them as part of our session here today. They're going to get into what sample pooling looks like. It's not quite as simple as just put 10 or 20 samples in a well and get 10 or 20 times output. And so they'll go into a case study that happened at a lab here that we helped set COVID sample pool testing up at, and go through sort of what the impact of that would be and how the cost savings and throughput would be affected by that. And so we're going to let these two statisticians share their knowledge with us. But before we do that, we're going to go ahead and give you just a broad 30,000 foot view of the industry and why sample pooling is relevant in the market today. So I'm going to hand it over to Dr. Sarah Howard.
Good afternoon. Thanks so much, John. Yeah, we wanted to start today by just giving a brief overview of the current state of testing in the U.S. As we know, testing has been rapidly evolving over the past several months. And through a really multifaceted effort, we've really ramped up testing capacity here. Currently, we're reporting about 600,000 tests per day, which is a huge improvement over April. However, many estimates are still showing that we're only about halfway to our true mitigation target. And what that means, the mitigation testing target, this aims to reduce the spread of the virus by broad testing of symptomatic patients. It also recommends testing about 10 additional people that a confirmed patient has come in contact with to aid in contact tracing. However, the symptomatic testing approach is often not sufficient to prevent new outbreaks, only identify existing ones. And we're still not even at the testing numbers that we would need to be to reach that. True suppression testing goals would be nearly double this goal that you're seeing on the screen, where asymptomatic patients are being tested as well to identify cases more quickly. So it's clear that even though we're on the right trajectory, additional testing will really be needed to get us to a place where we need to be. And especially as critical geographical hotspots emerge, such as Florida and Arizona, we're going to continue to need additional testing. So what are some of the barriers to testing expansion? First, there are supply chain issues. We've all heard in the news about supply shortages for COVID testing. This includes items used for collecting samples like swabs and transport media, as well as the actual items used for testing, such as the assay reagents themselves. Manufacturing of these items has really ramped up to offer some relief, but delays are still definitely occurring. There we go. I lost the screen for a second, but I think we're back. We're also now seeing a shortage of qualified laboratory technologists. Even if the lab has the capacity to expand testing, they're still going to need qualified personnel to run the samples. This is a specialized molecular test, and finding people to fill these roles can often be a challenge. And because of some of these issues, many of the labs are often now seeing a delay in turnaround time on COVID testing. Large labs are reporting turnaround times of 5 or more days. This is definitely challenging for people who are waiting on these results and do not know if they've been exposed to others, and they might be waiting to go back to work. This 5-day turnaround time can be very difficult for people. So in addition to these items, we also spoke on the last slide that a majority of the testing that's currently occurring is being provided to individuals with symptoms or that have come in contact with a symptomatic patient. Asymptomatic testing is still very limited. There's some at-home testing options, but these have a higher associated cost. And until we have the capacity to really be testing both symptomatic patients as well as asymptomatic patients, we're not going to be able to hit those suppression testing target goals. And now, on top of an already strained system, employers, schools, government agencies are all trying to implement their own testing strategy to avoid these large outbreaks as employees begin to return to work. And finally, something that labs are also facing are pricing and payment as a factor, as there still lies uncertainty with reimbursements, which may be impacting laboratory decisions. And new things seem to pop up every day. Most recently, a shortage of the actual instrumentation used for testing is occurring. One of the main vendors that use for automation equipment that we use for molecular testing recently told me that they were set up to produce 3 pieces of equipment a week pre-COVID. And recently they've received over 350 orders. Although they've ramped up manufacturing to about 15 per week, you can still see where the problem lies. There is definitely a shortage of instrumentation right now. So new instruments and equipment are often weeks, if not months, on back order. And so we really need new solutions to be implemented quickly to accommodate a growing test volume with limited resources. And with that, I'm going to turn it over to Dr. Joshua Tebbs to discuss a possible solution that's gaining a little bit of traction.
So the solution that's gaining a little bit of traction to this testing crisis is something that's known as pool testing. And pool testing gets its name aptly from the idea that when you collect specimens from people, whether it be blood, urine, swab specimens, rather than testing those individual specimens, what you do is you literally amalgamate them into a pooled specimen. And then you end up testing this pooled specimen, and it gives you insight to where positive individuals might be. Now, the number of different types of ways that you can do this pooling in order to gain testing efficiency, i.e. reduce the number of tests that you're having to perform, there's a variable myriad of ways to do that. So the original procedure was actually developed by Robert Dorfman back in 1943. His pool testing procedure was motivated by the need to screen World War II inductees for syphilis. And what he suggested doing is literally combining specimens that were collected from a number of different inductees into a pool and test it. If the pooled specimen tested negative, then you would diagnose all individuals contributing to that pool as being negative, and you've only spent one test. Whereas if a pool tested positive, then you would actually go through and you would retest each individual who contributed to that positive pool. Okay, so this idea of pool testing has gained a lot of traction over the last couple of years. And there are a few things that have to be thought of when you go through and you actually implement it. So one of the biggest things that you have to think about doing when you're implementing pool testing is considering what it is you're testing for and how that and what that looks like in the population being tested. So, for instance, if you're looking for something that is very rare, such as HIV or a rare disease, then you can actually design the group testing algorithm to be very efficient, where you have efficiency gains of 80-90%, meaning that you use 80 to 90% fewer tests to actually identify all positive and negative individuals. Now, if the prevalence of the disease that you're looking for is higher, say 10%, which is something that we might be seeing with common STDs or even COVID, the gains in testing efficiency are a little bit less, but you still can gain up to 30, 40, and possibly even 50%. And I'll kind of touch on a kind of an adaptation that you can make to the group testing paradigm that would allow you to confer even more savings in these kind of higher risk situations. But one of the big things here that you have to worry about is the validation of that group testing process for these different types of testing scenarios. Okay, so and what I mean by validation is something that we in the statistics community refer to as pool size optimization. So I think it's fairly easy to think about when you're looking at designing one of these group testing processes. What you're looking to do is to create many pools that contain only negative individuals. So you can imagine that if you build the pool to be too large and the prevalence is also large, then most pools will come back positive. And that's kind of the thing you want to guard against. And what we do is we actually use the prevalence of the disease within the population to actually identify what would be referred to as an optimal pool size based on some statistical calculations. And then we do this in an effort to actually minimize testing expenditure. So, and one of the big things that should be important to look at here, especially with COVID, is that we expect that the prevalence of the disease throughout time is actually going to vary, meaning that we may see a surge in cases, which would be an increase in the prevalence, which means that the group testing, the optimal design of the group testing algorithm being used would have to change through time. Okay, and to kind of give you an idea of what one of these little group testing algorithms could look like, and also how we could kind of optimize how the group testing is used within this kind of a large population screening scenario, we look at kind of dividing people based on whether they have symptoms for the disease or whether they're asymptomatic. So if you think about taking 100 people that are symptomatic and say that there's a 15% positivity rate there, one of the things that could be optimal to do there would be just to screen each person individually. And in doing that, you're going to end up expending exactly 100 tests. On the other hand, if you're able to break off the asymptomatic individuals and test them as groups, then the prevalence within the asymptomatic group could be as little as 1% or even less. At which case, if you have 100 individuals, that's like having one positive per 100. So if you pooled these 100 people into pools of size 20, then with one positive, that means that you would only have one positive pool. So applying Dorfman's screening procedure, you would have 20 pool tests, one of which that tests positive. Then you would have to screen those 20 individuals individually. So you would have screened 100 people at the expense of 40 tests, reducing your testing costs by 60%. Okay, so this is kind of an example that kind of demonstrates how the group testing algorithms could be used, and even how you could divide the population being screened. And what I'll do next is I'm going to kind of run through a case study where we actually do this with real data to demonstrate the potential gains that could be seen. Okay, so in this example, what we did is we had 3 weeks worth of COVID-19 testing data that was collected at a diagnostic laboratory. These test results were taken on 1,583 different individuals. And to more or less optimize the group testing procedure, what we did is we went through and we considered conducting a regression analysis of this data to understand the prevalence and how it was changing through time. This was done using binomial regression models with both linear trend parameters and also kind of a semi-parametric trend parameter. After a lot of model building was done and model selection strategies applied, what we discovered was that during this 3-week period, the prevalence was not really changing. And the prevalence came back to be about 12%. So this is I would think in the infectious disease realm, 12% is actually a pretty high prevalence. Again, this is not a prevalence of the entire population, but rather the population under study, which would be the people who are presenting for testing. Okay, so using this 12% prevalence, what we did is we went through and we identified the optimal testing configuration under Dorfman's original decoding strategy. And what that told us was that in applying this testing strategy, what we would want to do is construct initial pools of size 4. And again, when applied, what we would do is we would test the pools, then a positive pool would be decoded by testing the individuals separately. And once we had kind of identified this optimal design, what we decided to do is to go through and play the game of what if. What if we had actually implemented this testing strategy to test these 1,583 individuals that showed up to be tested? So what we ended up doing is we looked at within day pooling individuals in pools of size 4 and testing them according to Dorfman's strategy. In doing this, we accounted for the sensitivity and the specificity of the test to acknowledge the imperfections in testing. And we tabulated the number of tests required to actually screen this population. Now, to acknowledge this kind of multiple different sources of randomness we have from building pools to the imperfect test, we repeated this process many times and then found the average number of tests required to screen this entire population. And the average number of tests required to screen the 1,583 individuals turned out to be about 1,022 on average. So this accounted for a 33% reduction in testing cost. And that is within a population that has a relatively high prevalence. Again, the prevalence here was 12%, and we were still able to gain 33% cost reduction. Okay, so some realistic considerations to take into account when thinking about adopting group testing as a means to screen populations for infectious diseases is the sensitivity of the test. There is a common concern when implementing group testing that when you pool individuals together, the process of pooling, say, positive individuals with negatives, you would be diluting that positive signal that you would be looking for. And if you have a highly sensitive test, this becomes a less of a concern. So you would really want to look at implementing these techniques with tests that are highly sensitive. Um, and in saying that, you would also want to go through the process of validating whether or not the test that you're implementing still maintains that sensitivity across different types of pooling schemes. This would allow the diagnostic lab to actually shift and change in response to the changes in prevalences that could be possible, especially with respect to what we expect COVID-19 to look like over the next several months to years. And then the other thing that's has been a little bit of a challenge in the past that we've actually gotten past recently is the validation required by the FDA. And the FDA now is actually kind of streamlining the process of validating group testing techniques so that we can increase testing capacity. So I will turn it over now to
Yeah. Thank you, Dr. McMahon. I appreciate you pinch hitting on a couple of those slides too. And so I think we did have a few different questions come in. Lighthouse is currently helping several labs with validating this. So if you guys are interested in kind of what we talked about today and how that might apply in your lab, we'd be happy to help. And we're seeing that demand for this be always on the rise, especially with the FDA's more recent messaging, which seems to be very positive on it. Fauci's talking about it. There's really just been a change in the narrative on this in general. It's being used in Wuhan, and the states were a little bit late to adapt it, but I think that we're seeing a lot more acceptance of sample pooling as a part of the solution, and we really do feel like it's what's needed to start testing that asymptomatic population and get the testing capacity to where it needs to be. Some of the questions that I'll pose to the whole panel, and you guys can decide who wants to try to take it. And I think we covered it a little bit on that slide, but we have Michael and Brandy were asking about the dilution factor. So by pooling samples together, are we losing sensitivity in a meaningful way? Is the LOD still going to be there to be able to detect a positive, or are we going to have positive slip through that wouldn't otherwise? I don't know if Dr. Harris or Dr. McMahon, if you guys have any comments or thoughts on that.
I can take a swing at it.
So right now, sorry, go ahead.
Go ahead.
Okay, I was just going to start with saying the FDA guidance right now is pool samples of 5. So that's really where we've started. We haven't, the theoretical example of the 20, we haven't done that in practice, but the pool samples of 5, we are not seeing a loss in sensitivity. There are very specific requirements that the FDA is laid out for making sure that your LOD experiment is redone for pooled specimens, as well as making sure your sensitivity is still there. Most notably, taking a very multiple low-level positives that are right at your cutoff and then diluting them with negatives. And you have to show a certain number of replicates for that for your assay. Every assay is a little different, but in general, at that level, which is what the FDA is recommending, we have not seen a decrease in sensitivity.
Dr. McBain, do you have anything to add to that?
I would also add that the use of group testing for COVID right now is actually being group testing for COVID is being used by the Nebraska Public Health Lab, and they gained permission from the FDA to start that several months ago, and they've been doing that testing now. And to my knowledge, which again this is through personal correspondence, but to my knowledge, they have not had issues with dilution of that dilution effect.
Sure. Yeah, there's no evidence to show that we're missing positives, and I've heard that from multiple sources. How about the volume of the sample? There's some questions about how much volume, if you're putting samples together, how do you determine how much volume is taken from each sample, and is there a limit there where if you're getting to a pool size of a certain size that you're not getting enough of any sample for it to be valid for that individual? Either of you want to comment on that?
This is Sarah again. So really, there's 2 different approaches that we're seeing a lot of labs do, and it's pre and post extraction pooling. And there's benefits and cons to each. There's pros and cons to each of them. But really, if you're doing, pre-extraction, you're just taking a 1-to-1 to 1-to-1 and pooling them, and then treating it just straight as the EUA, as you treat it like a regular sample with your your regular SOP. You're not having to modify the volume that you're using. You would just be doing a 1-to-1-to-1 and treating it through the regular workflow. So volume isn't of a concern.
Great, that's really helpful. What about, we had someone asking about sensitivity of kits. Is that normally published by the manufacturer? They're wondering, is there data on the sensitivity of the different RT-PCR kits that are available?
So definitely there's going to be data published that should come with each of the EUAs, and it can be found on the FDA website. We recommend and the FDA does as well on their guidance of pooling, to use an established EUA, which includes a lot of this information, and it makes that transition from you can submit your pool data in this after you've validated it with because you'll still need to validate it per the EUA guidelines, per the regular protocol, because when you do have a positive pool, then you'll be running all of your individual samples. So it should come with that, but I think most of the ones that I've seen, we've done this on several different assays. We really haven't had an issue with sensitivity, especially at that pool size of 5. If we do get into the 20 plus, that might be different, but right now what we're showing is that's a solid pool size on multiple different assays.
Great. That leads into another question from Shalini, who wants to know, if you're only pooling 2 samples, do you still need to revalidate? I think I know the answer, but we'd love to hear it from the expert.
Yep, you do still need to revalidate. Any deviation from that 1 sample, 1 test is considered a revalidation, and you do need to follow the guidelines that the FDA have presented for pool testing.
Perfect. And there is a few questions about this slide deck being available. It will be available. A recording of this whole webinar will be sent out to the attendees, and so you'll have this with the slides and audio. But one other thing I wanted to mention, just to make sure it was clear, there seems to be some miscommunication about the savings related to sample pooling when I'm talking to a lot of clients. And there is a savings, and it's related to the consumables for testing, running that test. But you're still going to have the same amount of consumable costs on the collection side and typically on the extraction side if you're pooling after extraction. And so you don't save, by sample pooling 5, you don't have 1/5 of the cost. There is still the cost of those collection swabs and medium and everything that's needed to get it into the lab, and you're just saving on the actual consumables related to running that test. A question from Eric is, which assays do not lose sensitivity at a pool level of 5?
I can, maybe John, I can add the assays that we've done this on for when we publish the slide deck. I'd have to go back and look at all the different ones that we've done.
Sure.
I did also see a question come through about whether there was something that needed to be on the report indicating that it was a pooled sample. Yes. That is part of the FDA requirements, but it does have to indicate on the report that this was a pooled specimen. So that's something to note.
All right. Then we had one other last question just came in from Zayed of, do you extract before or after pooling? I believe there's maybe options there, but can you guys speak to that?
There are options. You can validate either way. We've been validating pre-extraction for various reasons. One is you're going to have additional cost savings if you pool prior to extraction, but there are some added benefits of pooling after extraction due to quickness of being able to rerun. So it's going to depend on a lot of things such as sample volume, and we'd be happy if it's something that interests you to talk really through the details of your workflow and what might make the most sense for you.
Perfect. Well, I appreciate you guys presenting this and sharing your knowledge. I am going to put out there an option for our WorkSafe program. That's a really good application for this, we feel. It is typically an asymptomatic population, and so we do have an offering for helping employers to screen their employees to make sure that everyone is safe to work together. If that's something that interests you, you'll see that on your screen. But please reach out. Here's our information. I'll put it up on the screen for you. If you have any questions, feel free to call us, email us, and we'd love to help. We'd love to help you validate this in your lab. I think the cost of getting sample pooling validated, you'll see the return on that pretty quickly if you have any substantial volume. So thank you guys all for attending today. We wanted to get you out of here in half an hour. We're right on 30 minutes now. that recording will be available, and we will be doing this every month. We'll do a different topic, and so we appreciate you joining us, and keep an eye out for future webinars. Thanks, everybody. Have a great day.
Thanks, everyone.
Thank you.